Welcome to this session, which, as you can see, is Statistics in Action, helping policymakers tackle the NHS waiting list. So if you weren't planning to come to that session, I'm sorry, the doors are locked. You're here. And we do promise to keep this session to time and shorter than the NHS waiting list itself, and so we'll get you out on time for lunch. If you allow me to introduce myself briefly, my name's Hannah Knight, and I'm from the Health Foundation. And I lead programs using data analytics to understand clinical pathways, improve care and influence policy. And this session draws on work by the Health Foundation. We're an independent charity that works to improve health and care across the UK. So the panel today represents work that was either done or funded by the Health Foundation's Analysis Directorate. We're a team of around 30 data scientists, and we apply statistical and data science methods to some of the most pressing questions in health policy. So on to the waiting lists. Well, as many of you all know, the waiting list in England now stands at over 7 million people, and reducing that backlog is one of the most pressing challenges facing the NHS and the government. As statisticians, we know and recognise that it's not just about describing the scale of the problem. It's really key that we model, interpret and communicate waiting times in ways that inform some of the difficult decisions that are having to be made. So the session today, we're going to hear 4 short talks by our panel. So firstly, Freya Tracey on uncertainty, politics and analytics in building projections of the waiting list. And then Freya will hand over to Tom Prendergast, who'll talk on using linked data to identify inequalities and assess the health impacts of waiting. Freya and Tom are both senior data analysts from the Health Foundation. Then we're going to hear from Jess Butler from NHS Grampian, where she's the lead data scientist, and she heads up the Network Data Lab collaboration at NHS Grampian. She's going to tell us about whether her modelling work to look at whether long waits generate excess healthcare use and costs, and where those costs are highest. And then last but not least, we'll hear from Zayad Issa, who's an economist at the Health Foundation, on applying queuing theory to the problem of waiting lists. So without further ado, I'm going to hand over to Freya. If I could ask you to submit questions on the app, if possible. I think there will be a roaming mic, but it seems like there might be some audio issues with hearing responses from the floor, so the app might be preferable. We'll monitor those, and we'll save them up for a Q&A session after we've heard from all 4 of our speakers. So please do think and reflect, and we'd love to also hear any reflections from any of you who've worked on sort of hot policy areas before as part of the Q&A session. So with that, let's get started. Freya, over to you.
Hi everyone, good morning. I'm Freya Tracey. I'm a senior data analyst at the Health Foundation, and today I'm going to be presenting less stats and more thinking about the challenges of doing highly politicised work in short timelines and how we tried to overcome these on some work we did in September 2023 on projections of the elective care waiting list. So, as you probably all know, elective care took a huge hit during the COVID-19 pandemic, with many procedures stopped and a huge backlog of people waiting for care following the pandemic. It's been a topic of political debate for a long time, and in January 2023, the former Prime Minister Rishi Sunak pledged to make reducing the waiting list one of the key priorities before the next general election, which could be no later than December 2024. There was a lot of public debate about it at the time, about whether these targets could be achieved, and particularly how much the industrial action, or more commonly referred to as strikes, that were happening at the time might factor into making these pledges a reality. Jumping forward, we now know that the waiting list hit a peak at 7.8 million in autumn 2023, before slowly declining, and now it's kind of fluctuating, but that the waiting list continues to be an important issue for the new Labour government to face. But we want to take you back to August 2023, where we wanted to understand what it would take to achieve the former Prime Minister's pledge to reduce the waiting list, and how we considered this under a range of possible scenarios. We'd like to spend more time reflecting on what it's like to conduct analysis at a fast pace in a highly political and uncertain environment. As analysts, we tend to love things which are clear, when no assumptions need to be made, and you feel like it's easy to be objective. But that, of course, is almost never the case, and therefore, so begins the presentation. We felt like this project in particular really brought out challenges of working with great uncertainty and high scrutiny. I'd also really be keen to hear from other people in the discussion about your own similar experiences, whether that's in healthcare or a different field, where you felt like you faced similar challenges to the ones I'm going to discuss. So first of all, to give you a summary of the work we did, our report started with a description of how waiting lists have changed over time and how this is informed by the changing referrals and completed pathways. The waiting list I'm discussing here is everyone in England who is waiting for consultant-led care, who has had a referral and not yet started treatment. To get the waiting list to shrink, you need more people coming off the list than going onto it. You come off the list as a completed pathway and you join the list as a referral. And I'll cover a bit more on the terminology around the waiting list on the next slide. So if that made no sense, hopefully it will next slide. At the time of our work, there was lots of discussion around industrial action and whether this was affecting the likelihood of meeting the pledge to shrink the waiting list. So it was important that we gave some context around the impact this might be having, as well as acknowledging what you can't understand within our analytical piece, like the longer term impacts, apart from just cancelled appointments on days when people strike. So you have the days when there's strike activity, and then there's that cumulative effect, which we weren't able to model. We modelled 4 scenarios to show range for what could happen between September 23 and the end of 2024, which was the last point at which there could be a general election, and therefore this pledge to see a reduction in the waiting list could be achieved or not. And these looked at whether hospital activity grew or stayed the same, and how long strikes continued, and then to what intensity. But with so much uncertainty around this, we also built an interactive calculator to allow users to explore their own scenarios, to see how much difference these parameters had on the waiting list, and what it would take to see the waiting list shrink. And the QR code here, which is absolutely huge, will take you to the full report. So the waiting list has some specific terms which can seem a bit opaque to those who aren't familiar with this aspect of healthcare, or indeed healthcare in general. So I thought it would be helpful to cover these so you're familiar with them for the rest of our speakers in the session. But note that these apply to NHS England, so Jess, who will be presenting about Scotland, will be covering separate terminology there. So the elective waiting list is formed of all pathways waiting for consultant-led care. So to join this, you need to be referred onto it, which is most commonly from a GP, but there are some other routes to referral. And this is when what's known as a clock start. Your clock stops when you leave the waiting list, and that can either be through starting treatment or by non-admitted means. People are either not admitted because it's decided that they don't need treatment and refer back to their GP, and that might be for something like active monitoring, but they also might leave the waiting list because they die whilst they're waiting or decide against treatment. And throughout this presentation, when we're talking about the number of incomplete pathways, this is distinct from the number of people waiting, as some people could be waiting for more than one treatment under different specialisms. So NHS England estimate there are about 84 unique patients for every 100 pathways that are completed. So it's not quite one-to-one. So here is the interactive calculator we built in R Shiny. The first graph shows the waiting list size, with the light purple bars showing what is modelled in the different scenarios and the dark purple bars showing the historic data. The second graph shows the completed pathways and referrals, and the changes in these informs the size of the purple bars. So again, the red bar bit shows the projections, and then the bit before that shows the historic data. In order to get the light purple bars to shrink, we need to see the completed pathways line ahead of the referrals line to get the bars to shrink over time. The 4 scenarios we considered, which are in the top corner, and users could click through these, are hospital activity grows at the same rate and strikes stop. Hospital activity grows at the same rate, but the strikes continue for the rest of the period that we're looking at. Then strike action continues and hospital growth rate is lower than the historical trend, so that's what you might call your worst case scenario. And then in our best case scenario, both the strike activity stops and the hospital activity growth rate is higher than this historical trend. If one of the very friendly people in the tech box can press play, then you'll be able to see over this image, it's like a little video. But if not, don't worry. So basically, it allows users to pick through the scenarios and see how the two graphs that are here can change, sometimes by not very much. And then users also have the chance to change the parameters. So in that top right box where it says create your own model, you could change things like the percentage increase in referral rates or the percentage change in completed pathways. And then you could also change things about the number of strikes that you were seeing, the number of months, and also the strike intensity. All the code is available for this on GitHub, and I will leave the way it works as a mystery because the video didn't work. Oh, now it's playing. So there's a model in the back end, so sometimes there was like a slight lag in terms of how it displayed the graphs. Perfect, thank you. So starting off with dealing with the uncertainty we had to work with. The waiting list should, in theory, just be a simple inflow-outflow model, but of course, it's never going to be as easy as you want it to be. People leave the waiting list without being recorded as a completed pathway. And that's a weird quirk of the data which we discussed with NHS England that had to account for in our work with some assumptions. For those interested in this, the Nuffield Trust have recently published some work on this, which is definitely worth a read, and we've had some conversations with them about it. Along with everyone else, we didn't know whether a deal would be made with the doctors at this time or if they would continue to strike, and then also how that would affect the change over the winter months in 2023. We also didn't know how referrals were going to change. It was expected that we would see this huge increase in referrals following COVID, as people were then able to access their GPs more readily and get these referrals to see their clock start. But we didn't see that to the extent expected. So in our modelling, we didn't know if there was still a kind of population of missing referrals who were yet to come forward. Our main way to deal with this uncertainty was through the interactive calculator to allow users to explore this uncertainty rather than making lots of tight assumptions. We did have to pick 4 scenarios, but by having these which could easily be compared by changing one aspect, i.e. strikes continue or strikes stop, it allowed people to directly see the impact of the changing factor. So we made decisions on these topics, and now we had to put them into our model. This is the part that we're probably all more used to, so making decisions and analytics. Part of the task was to make this an explainer of the waiting list, so we really wanted to ensure this was simple and explainable to non-analysts such as policymakers and stakeholders in the Department of Health as well as NHS England. So we didn't want a black box model which might do something very clever, but it wouldn't be intuitive. We also knew we wanted to ensure others could reproduce it and even challenge it because of how political it was at the time. So by having a very complicated model, it wouldn't be very able to be kind of critically challenged by critical friends maybe. And we had to balance a quick turnaround time that would help to influence policy more immediately, whilst ensuring that what we were doing was still robust and accurate. What we did to try to achieve this was to use only publicly available data, which did result in our findings diverging from what NHS England reported, as we didn't have access to the same data sources. And because of the quick turnaround time, we also settled on using a relatively simple model of linear growth, which looked at referrals and completed pathways per working day with a seasonality multiplier, because you see changes in this over the year. Obviously, the waiting list would never continue to grow in a straight line forever, but since we were trying to evaluate this against a specific short-term deadline with the next general election, which we thought was going to be December 2024, spoiler, it wasn't, we thought a linear model was good enough, and we tried to make very clear that this model wouldn't extend further than what is within the user interface and in our report. And then dealing with politics. So we had obligations and continue to have obligations as analysts who work for a charity to remain politically neutral. But we also wanted to influence change for the better when it's important to kind of make sure that the narrative is working towards reducing the wait list and allowing people to access care sooner. So whilst industrial action wasn't initially our focus, we ended up spending a lot of time thinking about the impact of strikes because it was a big conversation within politics and the media at the time. And we wanted to make sure we were answering these big questions and kind of giving space to allow kind of informed discussion on this. We also hoped the multiple scenarios and the custom user input would help us to avoid taking a hard stance as well, but we were aware that even things like the order in which we presented those 4 scenarios on our graph and in our write-up, as well as the visuals we used and our wording, would still have influence on our readers, so we had to be careful about that. And in the end, we couldn't find that strikes had as high an impact as other stakeholders had found, including NHS England's own projections, which were based on other data and methodologies. We tried to ensure any assumptions we made were backed with historical data, so we looked at prior data on appointments and procedures in non-strike months and compared them to completed pathways to see on average how many were needed for one completed pathway. We felt it was important to publish despite disagreements with the methods. If we were transparent, we could allow people to make their own judgments. And in the meantime, we had ongoing conversations with NHS England and other stakeholders to ensure that they had sight of what we were going to publish in advance and kind of had a continued open narrative with them. So we made our models, we published them, and then we waited to see how those matched with what we saw in referrals, completed pathways, and the size of the waiting list. So we published a kind of updated blog on this in April 2024, so that looked back at what we had modelled, and that's what these graphs now show. So the dotted line shows the modelled period, and the solid red line shows the real data that we then observed. So referrals were first looking very similar to our modelling, but then they came out lower than we expected at the time we did this follow-up piece. We're not sure why this was, but it's not necessarily a good thing to see your decline in your referrals because it might be a reflection on people's ability to access a GP referring behaviour based on what they know about wait times or how hospitals were accepting referrals. And then for our completed pathways, we saw a more similar real data to our modelled trend, but still slightly lower. But what we were seeing is that the red line, so that's the observed data, was sitting higher than what we saw pre-pandemic. So whilst the waiting list at this point was shrinking very slightly, it was more a product of fewer referrals than more pathways. So what did this all lead to? Our briefing and calculator had print, radio and TV coverage, which mainly focused on the impact of industrial action. That wasn't the initial focus of our work, but it was an important focus of the media at the time. It received good support from organisations such as the BMA, as it showed that the strikes were not the key driving force behind the growing waiting list. And it was important to us for continued conversation around industrial action to have fair representation of the impact, to acknowledge both the challenges for both those striking and those whose care is being disrupted. The work then had featured renewed coverage in the build-up to the 2024 summer general election, when there was much discussion around the NHS and particularly on whether the industrial action under the Conservative government had contributed to slower elective recovery. So our estimates around the impact of industrial action on the waiting list were covered on more or less after the first TV debate between party leaders, which was a great surprise to hear when listening to the podcast on the way to work one morning. And since then, we've continued to work on this interesting topic, as you'll hear from other speakers, as it's important to share with the public how things are changing within the NHS, as well as with stakeholders and policymakers who can benefit from the analysis that we do. So 2 pieces here that I've got QR codes for, which may be of interest, are on the left on whether the return to 18-week standard is realistic, and it models what changes in referrals and or the treatments that are delivered and needed to get there. And then we've also looked at the claims around the role of crack teams in NHS trusts and whether they can reduce the waiting lists. So the QR codes for both are below. I didn't work directly on either of these, but if you are interested, I'm happy to put you in touch with the authors who are happy to answer questions. Thanks for listening, and in the questions, I'm happy to take questions or hear from you about your thoughts on similarly highly politicised pieces of work. And now I will hand over to Tom.
Hi everybody, my name's Tom Prendergast. Like Freya, I'm also a senior data analyst at the Health Foundation. And I'm here to talk to you today about how we used, as part of the Network Data Lab, linked data to identify inequalities on the waiting list and also to take a closer look at the amount of healthcare that people were using while they're waiting for elective care. So as I mentioned, within the Foundation I work on a team called the Network Data Lab, or the NDL. So the NDL is a network of analytical teams funded by the Health Foundation, and we work together using linked data to analyze key shared issues in health and care. So the 5 labs that we work with are based in northwest London, Leeds, Liverpool, Grampian, and Wales, covering the entire country of Wales, all of which were selected for this project because they already had particularly advanced and extensive local ecosystems of linked health and care data. So in our work, we collectively select a new topic of focus every year, which we at the Health Foundation coordinate the analysis of between all the various labs, ultimately with the goal of producing novel analyses and achieving impact both locally and nationally. So the topic that we chose for 2024-25 was the elective care waiting list, and for this project, all labs, aside from our colleagues in Wales, participated. So in terms of why we chose to look at the waiting list this year and why we focused on the specific aspects that we investigated, so of course the waiting list has been going up consistently for over a decade, as we just heard from Freya, and because of this there's already been a lot of research into it. However, more often than not, that research has looked at the total numbers of people waiting and how long they're waiting for, rather than, for instance, looking at the characteristics of people waiting or the sort of outcomes that they face after their wait is finished. And this sort of research has been historically quite difficult to do because until very recently, the publicly available data on the waiting list wasn't detailed enough to look at individual characteristics or to break down wait times by demographics. And the patient-level data set that does exist, which in England is the waiting list minimum data set, or WLMDS, isn't widely available for research on a national level. So even though restoring elective care inclusively has been an NHS England priority since 2020, there hasn't, until very recently, been much research on inequalities on the waiting list. Similarly, there hasn't been much work on the impact of waiting on people or on the health system more widely, because in order to do so, of course, you'd need to link individual waiting list data with wider data on individual healthcare use. So these were two areas where we identified gaps and where we believe that the NDL, with its access to these very extensive local linked data ecosystems, could make a real contribution. So to try and fill those gaps, we examined 3 core research questions. And these questions were explored for all patients waiting for elective care, regardless of what procedure they were waiting for. So first we examined how long people were waiting, as well as the reasons that people are removed from the waiting list. And then we also looked at how much healthcare people use in the 3 months before they join the waiting list, during their wait, and then in the 3 months after they leave the waiting list. And for each one of these questions, we examined how all of these metrics vary by demographic and health characteristics. So the 3 English labs, so based in northwest London, Liverpool, and Leeds, tackled all of these questions, but then our colleagues in Grampian focused on the 3rd question regarding use of healthcare before, during, and after waiting. We should also note here that waiting times are defined differently between the countries in our analysis. So in England, they're defined in line with the referral to treatment standard, so beginning with an initial referral from primary care or similar, and ending with the receipt of first treatment, while in Scotland, waits were defined in line with the treatment time guarantee standard for inpatient care, which begins with agreement for inpatient or day case treatment from a consultant and finishes with that treatment. So between the English and Scottish labs, there are slight differences in the populations that we looked at, and also in terms of the periodization of wait times. So to start with results of our first research questions, this is how long people were waiting for and how this differs across population groups. So we found that although most waiters were waiting for 18 weeks or less, which is of course the NHS standard wait time, or the goal wait time at least, 27 to 33% of people, depending on location, were waiting for longer than that. So this is quite a way off the NHS target of 92% of people coming off the waiting list within 18 weeks. Then, when we broke that down, we found that waiting times differed dramatically by specialty, which we'll go into in a little bit more detail in a moment. But along with that, somewhat unsurprisingly, older people, people with higher frailty, and long-term conditions tended to have shorter wait times. So this, of course, isn't something we would think about as an inequality exactly, but it rather reflects local prioritization decisions based on clinical need. People who were waiting for more than one procedure also had longer wait times than people who were waiting only for a single procedure. But But otherwise, there did appear to be inequalities between ethnic groups and quintiles of deprivation in terms of wait times. So for example, we saw that patients living in the most deprived areas in almost all cases had longer waiting times than people who lived in more affluent areas. And people with Black, Asian, or mixed backgrounds all had higher average wait times than white patients did. And this was something that was consistent across all labs, and those disparities did generally remain even after adjusting for differences in age and deprivation profiles. This is also something that is reflected in NHS England's national level data on inequalities and wait times that was released a few weeks ago. However, what we didn't have was a cross-tabulation with specialties, so we can't tell how much of that variation was driven by differences in case mix. And as we can see here, specialty was the stratifier where we saw the widest range of variation in terms of wait times, both between categories but also between NDL locations. So as we can see here, while there are some that have uniformly long waits between locations, so for instance, trauma and orthopedics, where all the 3 labs that we worked with had pretty much the exact same long median wait time. In many cases, there's quite a wide range of median waits between the various NDL labs within each specialty. So for instance, neurology and neurosurgery are particularly high in Northwest London, and gynecology is especially high in West Yorkshire and Cheshire and Merseyside, so our Leeds and Liverpool locations. Then to look at our second question regarding why people were removed from the waiting list. So this was a question that we had trouble answering due to poor data quality. So in Northwest London and Leeds, around 40% of reasons for leaving the waiting list in the patient-level data were unidentifiable. However, the data was thankfully much better filled out in Cheshire and Merseyside, so in our Liverpool lab, where we found that less than half of pathways ended due to receipt of first treatment, so about 48% of pathways ended with treatment, while nearly a third ended due to a decision not to treat. And otherwise, once again, the most notable stratifier of reasons for leaving the waiting list was specialty. So we can see this specialty level difference here. There's some not especially surprising results, like for instance that plastic surgery had the highest rate of clock stops due to first treatment, while elderly medicine very frequently sees pathways ending due to the initiation of active monitoring, so someone's wait time essentially being paused because they're not fit for surgery at that point. But some curious ones include some very long waiting specialties such as neurology, gynecology, and ear, nose, and throat having quite high proportions of pathways ending due to decisions not to treat. So this raises questions about whether the long waits caused someone to drop off the waiting list, for instance, or perhaps that the problem had resolved on its own or developed into something else over that time. We should note that somebody dropping off the waiting list to pursue private options aren't separately identified here, but should fall into that decision not to treat category. So we don't know exactly how many people here might be responding to long waits by dropping off the waiting list altogether. And also, we are a little bit limited by our lack of comparators here, but one of our key takeaways is that this should really be a variable that's given special attention in future data quality improvements. Then our final main research question related to how much healthcare people used before, during, and after their waiting period. And what we found here was that aside from GP appointments and prescriptions, healthcare use was relatively rare across the cohort. The average weekly price of GP appointments was in all cases substantially higher than that of A&E attendances, despite an A&E attendance, of course, being a much more expensive form of contact with the healthcare system than seeing a GP. We also saw that deprivation was associated with higher healthcare use across all time periods, but in particular while waiting, and particularly in emergency care categories. And otherwise, something that we saw that was quite unexpected was that people tended to use more healthcare before and after waiting, rather than during the waiting period. And this is something that our colleague Jess Butler will be discussing in further detail shortly. We would assume, we don't know exactly why this is, but we would assume that this reflects increased healthcare use, possibly while trying to receive a referral in the before period, in the case of the English labs, who looked at kind of a pre-referral to outpatient care period. Or it could be kind of a sort of psychological reason where somebody feels more anxiety about a condition that they have before they've been guaranteed treatment or know when they're going to be treated. But And in terms of the after period, this could be because of care for complications or follow-up in the immediate aftermath of treatment. So these patterns did vary somewhat by points of delivery, however, and they weren't always consistent between specialties. So there was a number of specialties, especially those which tend to treat older patients, such as elderly medicine, which saw the highest rates of healthcare use during the waiting period, which might indicate some additional challenges for people waiting for those services compared to others. And we also found that the patterns of healthcare use in terms of when people used the most healthcare before, during, or after waiting also varied quite dramatically by wait length. So if we look in a bit more detail at that post-treatment period and then break it down into groups of wait lengths, we can see that longer waiters had relatively greater increases in healthcare use after treatment. So in this example for North West London, we can see emergency care go down compared to the waiting period for people who waited under 18 weeks, but actually go up for people who waited for more than 18 weeks, with the relative increase going up as wait lengths increase. We should mention here, though, that typically the shorter waiting groups, which tend to be older and more frail than the longer waiting groups, do almost always use a lot more healthcare in absolute terms than the longer waiting groups do. But what we were looking at here is relative differences compared to what they were using while they were waiting. So we can't say for sure that this is because of longer waits, because these groups do tend to be very different to each other, and there's many other reasons why they may potentially have quite different patterns of healthcare use surrounding treatment. But this is something that we, in a piece of follow-up work, aim to kind of drill down into a little bit more and perhaps really try to pick out what is actually the effect of longer waits on your use of emergency care in particular, but healthcare more generally following treatment. And then finally, in terms of variation between population groups, as I mentioned, deprivation seemed to be associated with greater healthcare use, and we can see here that there's a clear gradient. In this case, we're looking at A&E attendances per 100 people per week between the least deprived quintile and the most deprived quintile. So this was true in every time period that we looked at, so before, during, and after waiting, but the relative difference between the healthcare use of the most and least deprived quintile was highest during the waiting period in all labs. And what's depicted here is that difference during the waiting period. So that's all for me in terms of results, but we'd really like to thank the many, many people who contributed to this project. The NDL is really an ensemble effort in all cases, so thanks so much to everybody who worked with us on this. We have 3 publications related to this. So we have a briefing which unpacks all the results that I talked you through today, and then 2 blogs, one of which is focused on the policy implications of our work, and then one that's about working with the waiting list minimum data set and the challenges that we faced while doing that, and how we solved some of those challenges. So as I mentioned, we're currently scoping some follow-up pieces, one looking at emergency care, for people receiving elective procedures, and another project which will focus on the recently released data from NHS England on inequalities on the waiting list and discussing how that relates to our results. Thanks so much, and for a little bit more about our NDL work, I'll hand over to Dr. Jess Butler.
And if you have specific questions for one of our speakers, just indicate that, or if it's a question you'd like to ask all the panel, then you can make that clear, and we'll come to those at the end. So over to Jess.
So thanks very much. I am one of the network data labs that the Health Foundation funds. I'm the lead data scientist at NHS Grampian, which is the northeast corner of Scotland, about 650,000 people in our care, and the principal investigator of this grant. We're on our 6th year. And I think of us as like a small strategy unit that the Health Foundation has funded and put into an NHS site. And we do a different sort of deep dive every year. And so I'll talk to you about our results that Tom introduced that are specific to our setting in Scotland. So what do we know about waits? We know a lot about clock time for how long people wait, but not a ton more than that. So in Scotland, we have 2 waits, and it's sort of worth picking apart because I'll come back to it over the course of the talk. There's 2. If I have like reoccurring stomach pain, I keep going to my family doctor. We're not sure what's wrong with me. She decides finally I need to go to a gastroenterologist. and that starts my outpatient wait time. No one's sure what's going on. Eventually, I see my specialist, and that stops the clock. Now, my specialist treats me for a while. She decides I need surgery. There's a valve that needs surgery in my esophagus, and that starts a different clock time. So the blue one is sort of uncertainty. What's wrong with Jess? The orange one is we know I need surgery. I'm getting my valve fixed, but I'm just waiting for the treatment in the hospital. And that's my inpatient wait here. So I'll focus on inpatient wait today. Big picture, to hear what you've already heard, the wait lists are enormous. So in the past 10 years, 4-fold more people are waiting. 1 in 5 people in Scotland is waiting for healthcare. And it used to be almost no one waited over this arbitrary 12-week maximum wait. And now most people, 2/3 of people, don't get seen in 12 weeks. So this is a huge suffering problem, medical problem, and political problem. So what do we not know? So Health Foundation did a ton of really nice work there in terms of interacting with stakeholders, from patients to clinicians to NHS strategists, and we did the same at our local site. What do you want to know about your wait lists? They know remarkably little. They sort of march to the drum of reporting to Scottish government, but they don't do much deep dive work locally. And some of the things that came up, are people getting sicker? So are we hurting ourselves by making patients wait longer because when they finally do come in, they're that much sicker? GPs think they're paying the price. Because I'm waiting so long for my valve surgery, I just keep going back to my family doctor. So they never had to carry that burden before COVID, and now they do. It hasn't been measured, that's the feeling on the ground. And then there's this huge wait list. Currently, each specialty decides who gets treated next, and there's simply a 1 to 3 measure of clinical severity. That is it. So I think there's a lot that data nerds can add to this type of work to help prioritize that list. So who did we study? Who will I talk about today? We looked at everyone in Northeast Scotland who had a scheduled procedure at any hospital in 2022 or 23. So for us, out of our 650 total, that's about 51,000 people had a treatment in any hospital for 65,000 procedures. And what we did is we took that 51,000, and right now, no one who treated them knew much at all about their patient journey. So we looked back. We knew their treatment had occurred, and we looked back at their entire wait and said, what went on while you were waiting? So we know a lot about them as people. The NHS holds a ton of personal data on patients. So we know the reason for their procedure, like the exact procedure they were waiting for has an alphanumeric code. We knew exactly how long they waited in each part of the wait clock thing. Age, sex, and poverty, which is measured in Scotland as an index of deprivation for their home neighborhood. So we don't know the person's poverty level, we know the poverty level of their area. So with that, we knew that about the patients. Then we added up their hospital care, their secondary care, that's emergency attendances, A&E, and their unscheduled patient admissions. So everything that happened while they were waiting in terms of hospital attendance there, unscheduled. And primary care. So this is the saddest part of the talk. We know very well that they contacted primary care out of hours. That's data I can see, my team can see. Scottish GPs don't share patient medical records with the National Health Service routinely. They share some aggregate data. But we cared very much, the Health Foundation requested, and we cared very much about what people's primary care use was. So we came up with the best possible, albeit terrible, proxy for primary care. And so we can see their prescriptions. Oddly, GP prescriptions are shared. So we didn't count the total number of drugs, rather how many days I went to my GP while I was waiting and got a prescription. It's the best we could do for GP attendance. So big picture. We're always sorting by specialty. It drives the clinicians crazy, but here you go. These are the top 5 total waits for the types of treatment people were waiting for. So your hip replacement folks, your trauma and orthopedics folks treated about 7,000 patients who waited quite a long time, on average 33 weeks. So 300,000 weeks waited for those 7,000 people. compared to gastro, which sees about the same number of people much more quickly, so only 100,000 weeks waited. And this is a question that came up that people are always interested in, and we have a couple measures of this. Who used the most care while they were waiting? And we started with deprivation, with poverty. So this graph shows patient poverty level, where 1 is quite rich, not very poor, and 5 is high poverty, high deprivation. And throughout, I'll give you care use as attendance rates. So that's the number of times people went to A&E per 100 waiters per week. And so you can see wealthy people, the ones here, had about half the A&E attendance rate of the people who were living in the most deprived area. Huge difference. No fancy modeling needed. And no matter what type of care we looked at, we saw the same. Higher deprivation is higher care use while waiting, full stop. So here we have A&E attendance, days when they went to the GP for a prescription, primary care out-of-hours hotline, and unscheduled hospital admission. So we can say that people living in poverty needed much more care while they were waiting for a procedure. So we think about the personal characteristics, but we can think about sort of what's their medical need. So how does illness affect your healthcare use while you're waiting? And we saw big differences there. Here we've just ranked the specialties. For each person, we decided what specialty it was they were waiting for. And we can see that renal patients, people who have kidney problems, go to A&E at a much higher rate, 5-fold more often than the bottom there is orthopedics. So people with kidney trouble are going to A&E much more than people with hip pain, waiting for their hip replacement. And this is not a measure that our NHS considered at all. So the idea that you could categorize the waiters by type and think about, well, who are our high flyers at A&E, and focus on perhaps supporting them better. So that's a big one. Like, you can think, oh, A&E is a big worry. Who's coming in an ambulance? But we can also look at more subtle measures with all this linked data. And here's the patients who saw the GP most for antidepressants. And here we can see that people who are waiting to be seen at the pain management clinic had a much, much, much higher antidepressant prescription rate than other patients, for, say, cardiology folks down here at the bottom. So A&E is not the only measure of suffering, right? And NHS looks very carefully at A&E data, ambulance data, acute data, hospital data, but they don't look much at other measures of care use, human suffering and need during wait. So we had a whole bunch of measures like this. And we can say that care use did vary widely by social and medical need, but we can summarize that with this linked data at the individual level. So we can tell you which patients and which specialties have these high needs and hand it off to the decision makers. So this is the obvious question. This is the one we got a lot. Do people waiting longer for a procedure use more care? And on the face of it, you're like, of course. You know, instead of getting my hip replaced in 3 weeks, it was 33 weeks, and I must have needed more care. I must have gone to A&E more. One of the two big surprises we found is that's not the case. So here we have, along the bottom, our 51,000 people, and we grouped them by how long they waited in total. So on the left dot there, that's up by 0.6, is people who were treated within 12 weeks. These are people who got seen the quickest. They had the highest rate of hospital admissions while waiting. And as you get longer, the people here on the right waited over a year for their treatment, and they had the lowest attendance rate. I know you're numerate. Mind, this is a rate, right? It's not a sum of care. But if we're just thinking about the pace at which these people are getting admitted to hospital, the people who were seen quickly were the ones who were admitted to hospital most frequently. And again, we saw this for all types of care. So the people who were seen most quickly used the most A&E, rate-wise, unscheduled hospital admissions, called the GP hotline most often, and saw the GP most for prescriptions. So we can say people who used more care were treated first. So we're not making a decision whether that's right or wrong, whether it was a medical need or perhaps aggressively turning up at the front door, but we can report that this is the case. How does care change when people get added to the wait list? Subtle, but wild, the results here. So bear with me. These are that same weights we were talking about. So the blue is the 3 months where I'm seeing my specialist, and she's trying to figure out what's going on with my stomach. And we looked at the care use there, that's the outpatient weight. We then compared that to my weight once I knew I needed my valve surgery. So before I knew I needed my valve surgery and that transition to knowing I need my valve surgery, and what care do I use once I start that weight? So it's sort of the uncertain weight in blue and the, okay, I know I'm gonna get my surgery weight in orange. You could probably guess where I'm going. People's care use drops steeply once they get added to that wait list. Once I know I'm on my valve surgery wait list, my A&E attendance rate halves, on average, across the population. So these are the numbers, just the total average weights for the entire population in the 4 months before they get that put on that wait list for their treatment. Unscheduled hospital admissions are down 60%, A&E 46%, and then not much of a change for GP. So we looked into that a bit more carefully, and we can see many patients, when you sort them by what sort of medical need they had, their A&E rate halves once they know they're on that wait list for a treatment. So 50% decline in A&E attendance rate for most folks looking at these specialties, ophthalmology and pediatrics, the exception here. Kids always go to A&E. Ophthalmology patients are all very old, cataract surgery. Every specialty saw a decline in unscheduled hospital admissions once people were added to the treatment wait list. But primary care use was different. So here we saw there were quite a few specialties where the patients actually saw their GP more often once they were waiting. I knew I was on my wait list for valve surgery. I stopped going to A&E, but I'm still in pain. So I'm going to my GP actually a bit more often, with respiratory medicine and gynae up there at the top. So unscheduled care use, hospital care use dropped steeply once people knew what they were waiting for and that they were going to get treatment, but some primary care increased. So, summary, what should we do now? I give this presentation across the piece, so not mostly to analysts, mostly to senior people, chief execs, people who are running hospitals who aren't data folks. They love a suggestion of what to do at the end. So what we can do now is provide additional data about people to help prioritize who needs to come up the wait list first. We can very easily tack onto every wait list in the system people's care use rate in the past blah months. We can also add their home area deprivation. That was actually something that the chief exec team agreed to add to the wait lists. Data-wise, statistically, trivially easy, right? Once you get the counting working quickly enough. But it's just something they didn't have. We can also look at individual procedures, not just specialties, but exact surgeries where patients are coming in more. We can also support people while they're waiting perhaps a little bit better with that same data. So we saw that relief that seems to be coming through, that care use drop. And so it means we know which patients might need more support during that time of clinical uncertainty. So the patients are nervous because of their severe headaches and whatnot before they get a diagnosis, but so are their care providers. These unscheduled hospital admissions are the A&E team saying, I don't know what's up with this woman. Let's admit her and keep an eye. So they might need support as well for the certain small groups of people who use quite a bit of care. And this is my bugbear. We really need decent individual level primary care data in Scotland so we can help the GPs who are seeing this potential increase in workload advocate for more funding to care for people while they're waiting, things like that. So minimal data set sharing is one of my recommendations. So this is the report Tom talked about. This is the briefing paper that came out very recently from our work. We're one of 5 network data lab sites that worked on this. And while I have your attention, I think that the NHS needs so many more data folks and empowered data folks, people who are willing to make a claim at the end of a talk and make a suggestion about action. So if you're interested in either working for or working with the NHS, so one of our big things is also academic collaborations. We have a lot of data. So I'm here all week and I'd be happy to chat with people. And that's it. Thank you.
Excellent. Thank you, Jess, and ditto on her final remark. And we're going to hand over to our final speaker of this session, which is Zayed. So over to you, Zayed.
Hello, everyone. I am the last speaker of the session, and I know that we have had 3 very excellent sessions, so I'll try to make this as painless as possible, although we're discussing queues, so make no promises. So my title is Haven't Got a Queue, How Queuing Theory Can Help us think about optimal treatment decisions. And you'll notice there's an asterisk next to optimal. You'll see why. So why does queuing matter? First off, the elective waiting list is basically just one giant queue. And there is a really big push, as you've heard, to get it down to manageable numbers. And I'm using air quotes here because what that means is very different for different people. Oftentimes, when you hear the phrase fixing the waiting list, it usually means one of 3 things. The first is lowering the mean wait times. The second is lowering the total number of waiters. So you've heard people say, oh, there's 8 million people waiting, there's X million people waiting, whatever. And the third is meeting the NHS's elective constitutional standards. And what that means is lowering the proportion of people waiting above a certain target, in this case, 18 weeks. So this may shock you, but the NHS has capacity constraints. And given those capacity constraints, we can say that, okay, well, we could just throw more money into the system, treat more people, and we'll solve all 3, right? But given this existing capacity constraint, we have to ask, is there any way where we could change who we treat in order to optimize A and C? So IFS suggests yes. In 2025, they published a report where there was a bit in it that said you can treat the longest waiters in order to reduce average wait times, but as a result, you would obviously end up foregoing some clinical need. And the point they were trying to make was about the clinical versus efficiency trade-off. But we're statisticians, so we have to ask to what extent can we actually evaluate that statement? And that's where queuing theory can come in. So I won't go too much into it, but basically queues were founded by Erlang, yes, that Erlang, and he initially used it for in telephone operations. The way it works is that it's a very simple birth-death process, where a birth takes you +1, a death takes you -1, and if you have some assumptions about the general distributions of when people come in and go out of the system, you can find a steady-state solution for all sorts of nifty stuff, like the average wait times, how many people are in the system, et cetera, et cetera. And of course, a lot of this stuff is predicated on the assumption that all of it is Markovian. So what that means is you assume that what happens in period t only depends on what happens in period t-1. There are some non-Markovian solutions which are a bit more complex, but just putting it out there. And initially it was used for telephones, but it actually has quite a varied use in healthcare. Green in 2003, for example, demonstrated that it could be used for identifying ideal staffing rates in New York general hospitals. There's been quite a lot of work as well in A&E settings and in acute settings. Surprisingly, not as much in the UK as you would expect. And effectively, every single system can be more or less described using Kendall's notation. So it's MM, CK, and D. The first M stands for the inter-arrival time distribution, so that's the lambda for how often people come into the system. And M stands for Markovian. The second stands for the distribution of service times, so in other words, how long it takes for them to get treated. C is just the number of servers, so the number of, doctors or consultants. K and N don't really matter in our case. It's the number of places in the queue, and N is the calling population. And D is really where our piece comes in, and that's the queuing discipline. So how people queue, how they're prioritized. And that's what we're trying to vary to see whether or not it results in different outcomes. So in the very simplest case, where there's only one doctor and everybody is the same, the IFS is right. First in, first out, or first come, first serve, that's FCFS, is much more efficient. So what you see here is a comparison between first in, first out and whole, and this is just basically means that priority is randomly assigned. Some patient comes in and they get a random priority assignment. R is the mean wait times, and you see that actually first in, first out is so much more efficient, like almost 10 times under this particular scenario. It's also better utilized, and the queue length on average is shorter. Clearly that's it, right? We can all pack up and go home. Well, not so much. Not all patients are the same, and there's additional complexities. When we assume that patients arrive at different rates, this is where things start to get convoluted. So we know that there are different types of patients, but different characteristics, older people, more deprived people, and they tend to arrive at different distributions. If we suddenly assume that, oh, you have patients that arrive in different patient classes and they arrive at different rates, then it's actually much more efficient to prioritize them by how frequently they arrive. And it may seem counterintuitive at first, but think of it as like a traffic jam. If one car stops, everything else starts stopping as well, and you get like a jam that gets formed up. And the point is that the system is actually so much better utilized that you end up in a steady state where everybody is better off. And in this case, HOL assigns priority based on how often people arrive. So clearly, you can solve using all the matrix rate solutions for a multi-server, multi-priority system. It's completely solvable, and you can use this not very friendly looking equation in order to actually get that. But there is a caveat. It's not plausible if there are unequal service times. At that point, the maths becomes intractable. Having multi-server, multi-priority service with different service time distributions is not reasonable. And there's no closed form solution for it effectively. I mean, I'm sure there might be, but that probably is like multiple PhDs worth of topics, and it's probably not worth our time at this point. So what do? Well, we just say we give up on maths entirely. At this point, we just start using a discrete event simulation, which actually allows us to add the necessary richness for our work. In this case, I am using Simmer, which is a really good trajectory-based package by UCAR and Smeets. It depends on what language you code as well. There's other stuff, so you can go for SymPy. I personally don't really understand what it does under the hood. It's a bit of a black box for me. There's SymJulia, which is incredibly powerful, although it doesn't have the same, I feel, community support, at least for me, as Simmer. And of course, you can, if you know any low-level languages, you can do it in C++, or if you really hate yourself, in Java. So it's quite plausible. And how it works is we have this very basic queue structure, where you have a patient. They have, I don't know, some option of getting referred to the system or not by a GP or a community care consultant or anyone. And then they wait until they either get treated or they drop off the system. And that's how the simulation goes. And we simulate it as many times, in this case 100, as my computer would allow. And we do it for about, I think, 1,000 periods or so. In this illustrative example, we're turning off reneging and referrals, and I'll tell you a little bit more about it later. So, just to explore the different priority systems we have, this is basically just the relative priority per single patient. On the x-axis, you have how long they've been waiting, and on the y-axis, you have relative priority. So higher number means they're prioritized higher in the system, and it just basically shows you how that changes the longer they're waiting. In, first out, the longer you wait, the higher your priority, right? Makes sense. In last in, first out, which is LIFO, the longer you wait, actually the less your priority because other people come in. Then you have random and smart. So random is basically a time invariant, randomly assigned priority for you. It is completely independent of how long you've been waiting. Smart is our policy rule test. So this is a system that we've generated which basically says that you assign priority based on like some underlying patient characteristics, in this case, service times. And as you can see, it doesn't change regardless of how long you're waiting. And finally, target. So this is the fun one. This is basically a priority rule to minimize the proportion of people waiting above 18 weeks, which is that dotted line over there. And you can see it goes up and keeps increasing, and then after you hit it, that's it. You don't matter anymore. I'm not suggesting you do that. It's just a test. So if we run the simulation and we try and just do it just to make sure it all works out fine, actually it reaffirms our earlier results. So green is last in, first out. It's by far the least efficient. First in, first out is the most. And target actually is quite inefficient, but it behaves very differently until the simulation reaches steady state. And you can see the blue one is random. So again, reaffirms our MM1 solutions in the steady state. But let's do something fun. Let's try to think about how we add additional patients into the system. We have different patient classes, and we know that in the healthcare system, people often come in for very different reasons, and they have very different, let's say, mus or lambdas or arrival times and service times, right? So we're going to do an illustrative case here. We're going to create two patient classes. The first one is called Smoky Bad Health, who is an avid smoker, does not run, does not really take care of himself. They arrive relatively infrequently and takes much longer to treat, so high lambdas, low mus. Class 2 is Sister Prudence Goody Two-Shoes. When she's not at the convent, she does marathons. She arrives relatively frequently, and she takes much less time to treat, so relatively low service times. And then we can see what would happen when we start running our simulation using these different patient classes. It is actually, relatively surprisingly, much better to prioritize the prudences of the world than it is to do first in, first out. So this shows you the distribution of wait times that we do in our 100 or so runs across, I don't know how many patients end up in the system. You can see in, first out, it's roughly similar. There's perhaps a slightly higher mean wait times for the smokies, likely reflecting the fact that there's a slightly different arrival time distribution. But because of the way the prioritization works, it means that it's all roughly the same. Random is, again, the mean is roughly similar, but there's a much higher range, which is expected. But the smart one is interesting. So this is a priority rule where we effectively prioritize the prudences of the world over the smokies. And you increase inequality, yes, the prudences are treated much, in relative terms, much faster than the smokies, than in any other scenario, but it's Pareto optimal. So what that means is, in this scenario, everybody is better off because the system is better utilized. And when the smokies of the world come in, they find a system that's empty rather than one that is full. And it seems a bit counterintuitive, but it's actually quite helpful as well to think about it in terms of also number of people treated. When you have people available, when you have spots available in the queue, you can actually treat more people. So in this case, you can treat far more people under the SMART system than you can under a randomly assigned priority or first in, first out. And this sort of reflects that actually it changes not just A and C, as we've discussed, it also changes B, which is the total number of people on the system. Now, am I suggesting that you immediately just start asking people, how long do you think you're going to take in hospital, and then assign priority based off that? No, please don't take that out of it. What I am saying, however, is that queuing theory is an incredibly powerful framework that allows you to start thinking about policy. There is certainly a plausible scenario where treating the longest waiters, depending on who you are, could result in suboptimal outcomes for all patient classes. But the truth is, we don't know, because the data is sparse, and perhaps more importantly, is that there are a lot of additional complexities that are associated. So you've heard me talk about reneging, for example, when patients might leave the system if they might wait too long. There's also questions about fungibility of resource. So do the longest waiters consume the exact same type of resource that the shortest waiters do? Someone might need a specific diagnostic test, someone might need a bed. The operationally salient use cases for, I think, queuing theory is likely going to be pathway specific. But it is still useful, I think, as an illustrative case to start thinking about, well, what does this actually mean for the broader sense? And what does it mean for our thinking on who is on the waiting list? And the real crux of this is just that who you treat matters almost as much as how many people you treat. And that should also be a focus. And it should definitely necessitate some thinking about how rich and how reliable our waiting list data sets are. There's the waiting list minimum care data set, and I know that there is HES, but again, it's kind of difficult to use that. What we do know, however, is that there are some indications that the longest waiters on average have a higher length of stays in certain admitted pathways. And what that's telling you is, well, if you treat them now, yeah, you might bring down waiting times, but the long-term equilibrium, assuming all else is equal, is going to be higher wait times. So it's not always guaranteed that treating the longest waiters and doing first in, first out is going to give you better outcomes for everyone. It's not just a trade-off between, the policy problem of low wait times and clinical necessity. It can also be, like, simply put, that you don't actually know who's waiting and what that could mean for the system. There's a lot more work you can do here, but this is such a rich framework to be able to use. Simmer, and as well any other discrete event simulation you run, is actually much easier than you expect. And it can allow you to optimize it in such weird ways, and it's incredibly powerful. Effectively what I'm trying to say is to have a think about it from that point of view. And when you start working with the data, perhaps it might be worth asking, oh, who am I treating actually, rather than, well, how many people can I treat? Thank you. And if any of you have any questions, please feel free to ask me around.
Fantastic. Thank you, Zayed, for that extremely thought-provoking final talk. So we've had quite a few questions submitted through the app, probably more than we'll have time to get through. But we do have 15 minutes. Thank you very much to all our speakers for keeping to time. So I hope we can have a really interesting discussion here. There are mics at the front as well if anyone wants to come and ask a question or to share an experience of doing statistics in a similarly sort of high priority or controversial area. We've got some questions that are more clarifications and some that are more asking the panel for reflections. So I might just go through speaker by speaker first and do quick clarification questions. So perhaps starting with you, Freya. So the first question is, in your modelling, did you take account of staffing requirements to deliver the activity to reduce the waiting list?
So yes, but maybe not quite as much as if we were to do a long piece of work we would. So what we looked at was a conversion rate between the number of appointments and procedures and then the number of completed pathways. A conversion rate we calculated, I'm not going to make up because I can't remember the exact number, but it is in pieces of work we've published on this and is slightly different to what NHS England have estimated. But you obviously see that you need more appointments than you need a higher number of appointments than you get for a completed pathway. But what we didn't look at here was the staff mix. So when we say appointments and procedures, we're thinking about that's a very, very high level. What you're not thinking about there is in terms of things like diagnoses. So if you say had your first outpatient appointment with a consultant, they might then refer you to have something like, for example, an MRI to look at your hip. You're then using up resource there in terms of the MRI. You're thinking about the radiologist that's required to interpret the time spent there looking at then the MRI result. So we weren't looking at staff mix, but we looked overall at that conversion between appointments and completed pathways. So yeah, more could be done than we did.
Great, thanks very much. I think some of the earlier questions have subsequently been answered by other speakers. I'm going to skip to the question about the data on reasons people are removed from the waiting list. Mm-hmm. So other panellists may want to chip in on this as well, but based on your experience, do you think NHS England are receptive to the idea of publishing the reasons, or what do they already publish? From your interactions with them, do you think there's more that they have that they might publish in the future?
Yeah, I think this concept of unreported removals, like I mentioned, we kind of saw it as this weird quirk in the data, and it's become something that we've looked at more. Tom's looked at it a lot, and like I mentioned, this team at Nuffield Trust have looked at a lot, and they spoke to NHS England about it as well. NHS England presented at a conference a couple of months ago and shared their slides on that with us, where they looked at it. And we've had some interesting conversations with them, and we know that they're looking at it a lot. A lot of what they look at, they can't publish in the public domain, but I know that it's something that they are interested in. Obviously, Tom's work highlighted that at a local level, data quality is an issue on understanding why people leave the waiting list, apart from it being a completed pathway in the kind of traditional sense of having, starting treatment or receiving or having your hip replaced, which feels like a very finite way to complete your pathway. So I think there is lots of interest in it within NHS England, but I think there is some limitations. They are limited by what they can publish, but I don't know. And I would recommend reading the Nuffield piece as well if you're interested in unreported removals, but I don't know if there's something you wanted to add, Tom.
I suppose the only thing to add is, as Freya mentioned, there are quite substantial data quality limitations that need to be overcome for data like that to be published on a regular basis. So the figures that were presented by NHS England a few months ago, they didn't include all the categories that we looked at, and they did have kind of a separate tranche of unreported removals. So these are clock stops, essentially, that didn't have a clock stop entered, but that we can, through validation processes, sensibly assume is a clock stop. So, for instance, if somebody hadn't had any data entered into the waiting list minimum data set, it's collected on a weekly basis, and if someone's waiting, they should be receiving an update every week. But say, for instance, somebody might disappear from that data altogether. If it's been a very long time, there's been no update, that can kind of be assumed to have stopped for one reason or another, but we don't know why it stopped, essentially. It could be that the person moved away, the person could have died. There's many reasons. All of these things should be entered into the data as a clock stop, but they don't always. So what I would say is, there is a lot of demand for it. There's a lot of interest. What we've done fills in one tiny, tiny bit of that picture, but it is an area that in our conversations with NHS England is kind of going to be a bit of a focus, especially on the data side in the future, but I certainly wouldn't hold my breath for like a regular publication anytime soon.
Thanks, Tom. One more data-related question, this time I think for Tom. So the figures on decided not to treat seem high. Have you done any work on how much of this could be due to policy to reduce the lists?
So unfortunately not. So the figures that we presented are a snapshot in time, essentially. And the thing is, the waiting list minimum data set isn't very old. It's only really been usable, like it's existed since the autumn of 2021, but it's only really kind of been in a usable shape, for about 2 years or so. And what we did, because we took quite like kind of macro overview of the waiting list and all the different locations that we worked in. So we don't have kind of a time series of how these reasons changed over time, where we could kind of tell the results of a policy change, nor do we have because we were only able to secure those figures in one location because of data quality, we don't have comparators between different regions either. So essentially we can't tell that, but this is absolutely an area that anecdotally we might expect that to happen, but I mean, on the other hand, that's something that might be reflected more in referrals than decisions not to treat necessarily, but in any case, yeah, unfortunately that wasn't something that we could look at in our work, but it is absolutely a kind of crucial area of future research.
Thanks so much. Okay, Jess, question for you. Do you know how long people wait for between the two clock scenarios? So if they require outpatient and then they require inpatient, is there a gap?
There can be, yeah. So we'll know the whole wait list. It will be counted differently in Scotland than it is in the rest of the UK. And, we present this analysis of that care use drop once people get referred for treatment. And I have to say that the hospital folk, the inpatient folk, were very pleased. So care in hospital is monitored really carefully, and who's waiting for that type of care. And our results show that if you wanted to reduce an overall care burden, you might look more at supporting them during that time for the outpatient wait list. And that just simply isn't looked at as carefully, not because it doesn't matter, only because the data collection is just not as rich as inpatient data. So there is this idea that, interestingly, it might behoove us to change behavior way back in that outpatient wait, and that would reduce care use in the hospital as a knock-on effect. So it's a good catch. It's something we have on the to-do list, basically. We haven't tried to change any behavior with it.
Another question here for Jess. A lot of the findings from your work are really powerful. Are the senior decision makers listening?
Yeah, it's been fun. Like I took that same talk on tour, basically around the various groups across the health board, and the reception is really good. I don't think it's because the analysis was particularly novel or complicated or beautiful or whatever. I think it's simply that they don't often get a long narrative. Like they often get stacked bar charts, and then the analysts run back to the office. So the place that it was, well, I don't want to say best received, the place where the activity I think will be changed most easily is we actually have a team called the Waiting Well team. And the way they work right now is an entire specialty, so gastroenterology, will give the Waiting Well team their wait list. And they will literally just go down the list and phone people, like in alphabetical order, and say, how you doing? Do you need any additional support while you're waiting? They're not clinicians, but they're sort of like signposters. And so they were really pleased that there was potentially a different way they could approach who to call next. So rather than just taking all of the orthopedics list and going there, we can give them a list that's specialty agnostic, but of people who are coming in much more frequently to A&E. And so people who might really need that care more. So the Waiting Well folk were just like, yes, let's go. In terms of actually changing how people are prioritized on the wait list, like not our job to make that decision, and clinicians get so salty. Like to make it perfectly clear, we don't think they should change their priorities, but we can provide them with literally like 3 extra columns of data that they can glance at among the other ways they're organizing their wait list. So they were happy to put deprivation measure on there. I think they should put care use frequency as well. Nothing matters until you do the evaluation, like are they looking at those variables? So it's sort of a long-term project. You get the agreement to add the poverty measure, and then you get it put into the pipeline, and then you see if they'll agree to an evaluation in 6 or 12 months' time, and then you figure out how to present the evaluation to aggressive cardiologists. So it's definitely a big picture, but I've been really happy. Like every time I give this talk, like I get a few emails like, oh, can you come talk to our group? So far the reception's been really warm, yeah.
Maybe elaborating on that, a question from me is for all of you, sort of we often talk about the evidence policy gap. You've all had experience working on this topic of interacting with policymakers either locally or nationally. Have you found particular ways of communicating your work or the uncertainty, trade-offs around it that have been particularly effective? I get you've also all worked in different sectors before your current roles, so it'd be interesting to hear how that's been for you with wearing different hats.
So for me, I would say kind of one of the most beneficial practices that we've had is early engagement, basically, is in the very early stages defining your research project, engage the decision makers who can actually take action surrounding the topic that you're looking at and find out what is it that they need to know. Because the analytical capacity of many of these decision-making bodies is, they need to know a lot. They need to know, if they had it their way, they would know everything about the topic that they're looking at, but you can only know so much, and the role that we can kind of play then is to be the necessary analytical capacity. And we can do that by essentially finding out what they need and what can we offer, like what are the skills that we can offer in terms of the data that we may already have access to. In the case of the NDL, it's these really extensive linked data ecosystems, and basically find out what is the key role that we can play. And then once you've already done that, you kind of have an existing audience who really want to know what you've done and have an immediate use and kind of actionable plan for what you deliver as well.
I think something I would add on ours, so as I mentioned, we had some different approaches to NHS England on the way we looked at it, and some of that was as a result of using publicly available data, and some of it was by kind of the transparency we wanted to have. But I think having that open dialogue with them and identifying why we had differences in the data that we were presenting, giving them a heads up that we were going to present things that were different as well, meant that they could kind of we could stay as each other's critical friends, with the emphasis on friends and less on the critical bit. I think there were parts where we knew that they might have different approaches or different priorities as messages, but we kind of had to hold steadfast in the approach that we were taking because we wanted it to be this kind of transparent approach. And then by sticking with that, I think we've managed to kind of build up a good rapport with the elective modelling and elective recovery teams within NHS England, and it's allowed us to kind of go forward onto other work. And I think respecting the differences that are there and viewing both approaches are valid, I think was a good, positive outcome and something I've tried to continue with in future work.
Fantastic. I think that is all we have time for, and I'm not going to break my promise or miss the target that lots of people have made commitments around waiting lists. I will keep my promise. But I'd like you to all join me, please, in thanking our speakers. If you had a question that you didn't have a chance to ask, please come to the front and we'll hang around for a few minutes. Thank you so much for coming to this session and enjoy the rest of the conference.